So, I will be covering my talk in all these headings: the definition of epidural neuroplasty, the anatomy, the indications, contraindications, material used, techniques, complications, and then we'll analyze some contrast patterns. So, what is the definition of a neuroplasty? So, it can be performed by two routes, the transforaminal and the caudal route. So the caudal one is famously called as a percutaneous epidural adhesiolisis or the RAX procedure. It is named, it was, you can say, invented by Professor Gabor Rax, who was an Hungarian origin person. And these neuroplasty, they are minimally invasive image-guided interventions which are designed to break up chronic scar tissue, that is the epidural fibrosis, and wash out pro-inflammatory substances surrounding the spinal nerves. Now, what is the difference between a conventional epidural steroid injection and a neuroplasty? Is that in the conventional epidural steroid injection, we simply deposit the medication into the epidural space, whereas in neuroplasty, we utilize a specialized steerable catheter to mechanically disrupt physical adhesions, allowing medications to precisely reach targeted, compressed, and what I call it as an angry looking swollen nerve root or a dorsal root ganglion. So basically, we do it with the help of a RAX catheter. To be extremely frank with you all guys, I usually do not do this procedure because of the non-easy availability of the RAX catheter, and the other ways also to treat such type of patients. Now coming to the anatomy. So if, as you can see here, before we do any procedure, we should know two type of anatomies at least. One is the normal anatomy and then second is the fluoroanatomy. So we know here that these are the two vertebrae, and there's a foramen in between these two vertebrae. Foramen means simply an opening. So now what are the boundaries of the foramen? The superior and the inferior boundary. So you can see here, so this is the foramen, okay, the superiorly by the pedicle of the, suppose if this is L4 and this is L5, superiorly by the L4 pedicle and inferiorly by the L5 pedicle. Then posteriorly, this is the lamina and the facet joint, and obviously the LF, that is the ligamentum flavum. Anteriorly, the lower half of the upper vertebral body, the disc, and the upper half of the lower vertebral body. Okay, in L5S1 level, the LA will replace the pedicle. So these bony structures, they are visualized on a lateral view. So now, so this is an AP view, you can see here. So again, now coming to the fluoroanatomy. So this is a vertebral body. Suppose say this is the L4. So this is the pedicle you can see over here. So pedicle, the transverse process. I hope you can see my cursor. Anshul, Dr. Nana?
I can see. We can see your fluoro.
No, can you see my cursor when I'm...
Yeah, cursor is little small, but we can see. I mean, mobile is very difficult sometimes, but yes, people who are watching on laptop, I think they can.
Okay.
Easy.
So again,
Can be seen, sir.
Now it can be seen. Against the dark background, it is seen properly, but it's like
okay. I got it. So if you see here, so this is the pedicle. Now this is the superior articular process, the transverse process, the inferior articular process, the lamina, you can see over here. This is the spinous process. The opposite lamina you can see over here. The other side inferior articular process, the transverse process, the superior articular process. You can see this is the facet joint you can see over here. Okay. So this white structure, this is the interlaminar window. Okay. So now whenever you are doing a procedure, you have to square the vertebra. That means you have to overlap the vertebral end plates of the vertebral body in picture. Okay. So this is a AP view. Now this is the sacrum, this is the iliac bone. Okay. Now, when you do an oblique, so you see this image. So this is called as a Scotty dog image. So if you see, this is a Scotty dog. Okay. So this is the mouth of the dog. These are the forelimbs. This is the body. This is the hind limb. Okay. So if you see here, so this is the Scotty dog. You can see the ear of the Scotty dog, the snout of the Scotty dog. This is the face. These are the forelimbs. This is the hind limbs, and this is the body. Now, what are these structures? So this is again a vertebral body, the superior articular process, the transverse process, the pedicle, the inferior articular process. This is the spinous process, which has moved to the opposite side when you do an oblique on one side. So this is a left oblique view. So the spinous process moves to the opposite side, that is on the right side. Now, so the idea of doing this is, now if you see here, so where is the foramen? This is actually the foramen, okay, but it is obstructed by the superior articular process. So if you want to enter into the foramen, you won't be able to enter the foramen in an AP view. Why? Because the SAP is going to obstruct. So now we will have to open up the foramen. So to open up the foramen, what do? We tilt the siam obliquely towards the area of interest. So area of interest, supposedly, if this is the L4-5 level. So now we move the siam on this side. Now, how much siam to be moved? So there is a very fancy terms of 10 degree, 15 degree, 20 degree, but if you ask me, so there is nothing like degrees, because the orientation of facets is different in different patients and at different levels of the vertebral body. So you just have to see an obliquity in how much it is you are able to see the foramen, and you don't have to be precise on the degrees. Okay, so now we have moved. So now if you see here, so the foramen is opened up. You can see so much of the foramen opening over here. So this everything is the foramen. Okay, so now if we have to go through the foramen, so you have this much area to enter into the foramen. Now I already told about the Scotty dog. So this is the Scotty dog appearance. Now what happens is, suppose if you have to do a epidural injection, so you can see here in the model that this is the foramen which has opened up. So this is the foramen which has been opened up here. Now there are various approaches like the infrapedicular or the subpedicular approach and the infraneural approach and the Kambin's triangle approach. So if you see here, so if you enter here in the foramen, so there is a technique in which if you bend the needle and you target the lower part of the pedicle, and you advance your needle up to the pedicle. Now once it touches the pedicle, then you take a lateral view, okay, and then turn your bevel caudally and then enter into the foramen and see the depth, and again take an AP view and then do a dye study. So I'll show you what I mean by all these structures while showing you the procedure. So now coming to the anatomy, what are the contents of the foramen? The largest content in the foramen are the spinal nerves and its roots contained in the dural sleeve. So now what happens is, this nerve root, it curves parallel to the medial and inferior margin of the pedicle. You can see. So this is the pedicle. So anterior inferior margin of the pedicle, the nerve root curves and it comes out, that is it exits. So it crosses obliquely behind vertebral body, above level of the disc and below the pedicle. So you can see over here at the level of the disc and below the pedicle. It is accompanied by the spinal artery. Obviously, wherever there is nerve, there will be a vascular bundle as well. So artery and veins are also there. A radicular branch accompanies the nerve roots into the thecal sac, and these arteries are obviously accompanied by the veins. So you can see also this bulb-shaped structure is basically a dorsal root ganglion. So this is dorsal rootlet. This is the ventral rootlet. They join to form a spinal nerve. Now there is a fancy term which is called as a safe triangle. So initially the injections were being done in this safe triangle, and it was thought that there is no nerve root over here, so that it is a safe to enter through this triangle. So now what is a Kambin's triangle approach? So if you can see, these are the pedicles. Suppose this is L4, this is L5. So this is the L4-5 disc. Now this is the exiting nerve. So this is the exiting L4. This is the traversing L5 and this is the exiting L5 at L5S1 level. Okay. So basically this is the safe triangle which is subpedicular. Okay. So this is the pedicle, below the pedicle which is subpedicular, and it is above the exiting nerve root. So this comes into the upper part of the foramen. I told you the superior and inferior boundaries of the foramen. The superior boundary is the pedicle of the above vertebra and the inferior boundary is the pedicle of the lower vertebra. So this whole thing is the foramen. So in subpedicular approach, you will enter into the upper part of the foramen. Okay, just below the pedicle, and obviously it will be above the exiting nerve root at that level. Now, what about Cambin's triangle? So, Cambin's triangle is actually, it is below the nerve, exiting nerve root and lateral and parallel to the traversing nerve root. So, you can say that it basically, this is the axilla of the L45 disc. Okay. Now, what happens is, the boundaries are basically the hypotenuse formed by the exiting nerve root, the body and the disc. So, this forms the Cambin's triangle. Okay. So now a very important point about reinforcing medullary arteries. It is very critical. All the levels spinal nerves supplied by radicular arteries, which accompany dorsal nerve rootlets to spinal cord and supply the posterior spinal arteries. Now sometimes a reinforcing artery may be present. They enter ventral to the spinal nerve and accompany ventral rootlets to supply anterior spinal cord via the anterior spinal artery. Now this is very important, and the largest of these anterior spinal arteries, they are called as the artery of Adam-Cavics. So usually it is at thoracic lower thoracic level, but can occur anywhere from between T5 to L5, and more often it is usually on the left side. So it is rare at lower lumbar levels, increased incidence at upper levels. And when suppose the complications, vascular complications, if at all they occur, God forbid, they should not happen to any of us. But it is obviously reported in the literature. There are a lot of cases which are reported, and it is because of the mechanical clogging of the artery of Adam-Cavics. What are the indications of performing a transforaminal and a caudal? First is the diagnostic and the second is therapeutic. Diagnostic is to determine the symptomatic level in multi-level herniation. Now, suppose if the patient is having a radicular pain in the leg and patient comes to our OPD and we do a clinical examination, we see a MRI and the MRI shows that the herniation is at L3, 4, L4, 5, L5, on all three levels. Now, what do? If somebody has to operate, should they operate all the three levels? Should you have to do a procedure? Now, in such cases, what are you going to do? You will do a transforaminal at L3-4, at L4-5, at L5-S1, all three levels, or what? So, one of the indication is diagnostic. So, you can determine the symptomatic level. A therapeutic in case of herniated disc, stenosis, post-Cameron syndrome, and in cases of the epidural fibrosis. Now, what are the contraindications? Obviously, an unwilling patient is an absolute contraindication. History of anaphylactic reactions to contrast, untreated localized infection in the field, that is local infection, patient unable to cooperate during the procedure, allergy to any of the drugs, including the dye, pregnancy, anticoagulation, systemic infections, respiratory or cardiac compromise. These are relative contraindications, immunosuppression, and a progressive neurological deficit. Now, what are the things required to do these procedures? Fluoroscopy, emergency resuscitation equipment, prep tray, needles, spinal needles 20 to 25 gauge, short bevel, sterile gloves, cap mask, a connecting tubing, water-soluble non-ionic contrast like Omnipac, local anesthetic, steroids like a dexamethasone, triamcinolone, or dipomedrol, and obviously basic ASA monitoring. Now, again, this is a classic AP view if you are going to do the procedure at this level. So now suppose we are doing the procedure at L5S1 level, you have see, if you appreciate here, I have squared the vertebra and I'm going into the through the infrapedicular approach. You can see the needle tip bend. So I have bent the needle, and I'm going into the AP view. So this is the foramen which has been opened up. You can appreciate over here. This is the superior articular process of L5 and this is the ala of the sacrum. This is the pedicle over here, the superior articular process, the transverse process, the inferior articular process. Okay, so this is a ipsilateral oblique view, or a classically what we call as a Scotty dog view. Now we advance our needle. You can see that here that there is some bone in front of my needle. So it is actually a safety feature that I will not enter the pass beyond the pedicle. And we in intervention terminology lingo, we call it as that bone is our friend. Okay, so if there is a bone in front of us, even if you don't do a lateral till the point you hit the bone, it is okay, because you have a bone in front of your needle. So you can see I'm maneuvering my needle. Now once when I come when I touch the pedicle, the lower 6 o'clock to the pedicle, like here. Now what do? I turn my bevel down. You can see here. So this is my bevel which is facing up. Now once I have hit the pedicle, now I know that this is a time to take a lateral view. So now what I do, now I turn my bevel 180 degree. So this bevel is turned 180 degree. Then I take a lateral view. Then I again turn it cranially after advancing a little bit, and I take a lateral view. So you can see this is the pedicle. So I just crossed the pedicle and I am into the upper part of the foramen. So now this is called as a DDD technique, that is direction depth direction technique. So here it was the direction, whether I'm going cranially, caudally, medially, or laterally. Now I do a lateral view. So this is a depth technique. Depth, I am seeing the depth. So it is a direction, then now depth. So I'm going inside. You can see over here. Now I have come into the anterior part of the foramen. Okay. Now here what I do, I again take a AP view. Now whenever you change a view from a AP to lateral or oblique or whatever, whenever you place a needle and again take the Siam view in again in the other view, like here it is in lateral. Now I'm going to shoot in an AP view. So whenever you do that, you should have in your mind that where is your needle going to be, if it is a correct placement. So I can say that my needle should be at the 6 o'clock to the pedicle and not medial to it. Okay, so now you can see here. So this is perfectly at the 6 o'clock to the pedicle over here. Now here I do a dye study. So you can see here. So this is a exiting nerve root. Now with this technique, you can address pathologies of only the exiting nerve root. Suppose at L5 S1 herniation, the S1 nerve root is also getting affected, and you want to do injection at the S1 DRG also, then obviously you have to use a Cambian's triangle approach. Okay, now you can see here that it is an anterior epidural spread, and this is the exiting L5 nerve root. You can see here the exiting L5 nerve root in lateral. So this is the epidural anterior epidural spread, and this is the exiting spread. Now just to show a little bit of the Cambians, though this is not a classical Cambians, but still, so this procedure I'm not doing in a gun barrel technique. So don't get bogged up with it. There are various ways to do a procedure. This is just one of them. So I'm going into the foramen, and then I take a lateral view. So I have entered into the foramen. Now I go deep. So, whenever you are doing a Cambian's triangle approach, be very careful, because, many of the times if you try to advance the needle more up to the anterior epidural space, since there is a herniation over here, your needle tip might be into the herniation. And these are the cases when you will do a dye spread, you will have an intradiscal spread also. Okay, so be very careful. Now again, we take a AP view and do a dye study. So you can see this is the dorsal root ganglion, and this again the dye traversing inside, going into the L5. Okay, so this is in the anterior space. So always be very careful. If you want to do both, then you have to do a Cambian's triangle approach. What can be the complications? The infection like epidural abscess, bleeding, spinal headaches, nerve damage, intrathecal injections, allergic reactions, and injection into a radicular artery. So one of the most common complications is actually a vascular spread. Whenever you do a dye study, that's why always do a dye study in a live fluoroscopy. Never do a dye study in a static fluoroscopy, because I have seen many pain physicians, they inject the dye and then they shoot. Okay, so if you are doing that, you 100% of the times you are going to miss any intravascular spread. One more thing, that many other times the dye spread will be beautifully into the foramen, as well as some of the dye will be going intravascular. So in case of static dye study, you will see the dye to be into the foramen and you will think that, it's a very beautiful dye study. But what you will miss is that part of it was into the vessel as well. So bottom line, always do a live fluoroscopy injection dye study. Now, steroid and embolic episode, I'm not threatening you with what will happen. Forget all this as of now. Now, relation to, I'm not taking this slide as well. So, what are the maneuvers that you can do to minimize the risk of intravascular injection? So, so there are various methods. So we can use blunt needles in place of sharp needles. We can use non-particulate steroid like dexamethasone. Use of extension tubing so that you can do the dye spread in a live fluoroscopy. Local anesthetic test dose given. Continuous fluoroscopy, I cannot stress more about it. And use of DSA if the facility permits you to do your procedures in a DSA and in a cath lab. Three main things: inject under real fluoroscopy, center AP view to point of injection so that you can visualize at least 2 segments upwards, and be extremely vigilant during the injection. So again, it's the same slide. Now coming to a caudal access. So you can see over here, usually we do in a lateral view. You enter from the sacral hiatus and don't go above S2 because the dural sheath ends at S2. So your needle should be around at the level of the S3 vertebra, and then do a dye study in AP. You should be able to see a Christmas tree appearance you occur here. Okay. So this is basically the caudal access. The caudal access is done mainly for L5 S1 herniations only. Now, patient position and mapping this is more of a theoretical thing. Just try to comprehend whatever I am saying. So place the patient in a prone position with a pillow under the abdomen to flatten the lumbar lordosis. Use AP and lateral fluoroscopy to identify the anatomy and mark the sacral hiatus. Local anesthesia and access, prepare a sterile field. That's okay. So this, if you are doing neuroplasty with a RAX catheter, then you will get a curved RX Coude needle that is called as a Epimed needle. Epimed is the company of Professor Gabor Rex. So this is basically a blunt tipped needle. So you enter it through a sacrococcygeal ligament into the sacral canal. Then confirm proper needle placement inside the sacral canal using lateral fluoroscopy to avoid intraosseous or subcutaneous placement. Inject a non-ionic contrast, and then you will see the filling defects can be seen in the epidurogram. So this filling defect will be the area where scar tissue prevents the contrast from flowing over the nerve roots. Then advance the catheter up till that point. Suppose if the adhesions or it's a failed back surgery and the laminectomy at L5 S1 was done. So you reach up to the L5 disc, do a dye study, you will see the filling defect. Then you steer the catheter in and out, to try to mechanically lyse the adhesions, and then we lyse it through some other mechanisms which I'm going to take. So this is the mechanical adhesive which I already talked about. Then perform negative aspiration to ensure the catheter hasn't entered a blood vessel or the subarachnoid space. Administer a tri-phase therapeutic injection. Phase 1, hyaluronic acid mixed with local anesthetic to dissolve the collagen matrix of the scar tissue and provide immediate pain relief. Phase 2, steroid to suppress the localized inflammation. And phase 3, slow infusion of hypotonic saline 5 to 10% NaCl, which acts as a powerful anti-edema. It is basically hygroscopic, and it reduces the edema from the and shrinks the swollen nerve root. Okay, once the procedure is done, then remove the catheter and needle as a single unit. Okay, and put a dressing. Now coming to a very important thing, interpretation of dye spread. So these are very sort of literally some poor images, pardon me. These are actually the images from 2007, 2008. These were my initial days of my practice. Now you can see over here, this is the dye spread. You can see a nerve root over here, and not much of it is going into the epidural space. If you take a negative image, so this was a negative image, you can see. So this was more of an intraneuronal injection. Okay, then you can see, so this is the dye spread, and you will see a central spread over here thick. So that, what does that mean? It means if you take a lateral view, then the dye spread would be in the anterior as well as in the posterior epidural space. So this spread will mainly be just anterior to the ligamentum flavum. Okay, so this spread you will get while doing a conventional interlaminar epidural. So with a transforaminal, with a so many other times you can get dye spread in the anterior as well as in the posterior epidural space. Now, this was my second or third case in 2007. So I was very happy that I had done a very good job. Then a couple of years later, when I evaluated that what I had done, then I knew that it was a sauce injection that I had done. In 2007, unfortunately, we did not have uh, many people to teach us or to learn from. So we had to learn all by ourselves by seeing in the books and by learning ourselves. So this was a very little, I thought that I had done a wonderful job. A patient unfortunately did not get any relief. And when I saw my images, then I got that I had done just a simple sauce injection. Now we can see this is the laminectomy defect. So, patient was having this groin pain. So I thought of doing a diagnostic and a therapeutic injection. So I put my needle over here. So if you can see here, so this is the facet joint here. Now this is the facet you can appreciate over here. So my needle tip is just entering into the foramen. Now when I did a dye study, so this was an intra-articular facet dye spread. You can see here. So this is the facet joint spread. Okay. Now what I did was I just advanced my needle a little bit more. You can see here. Now again I did a dye study. Now what happens? Now the dye goes into intradiscal space because there was a reherniation and all the tissues from a previous surgical scar. So the dye went intradiscally. Okay. So you can see, so when your needle comes from here and your needle is here, so this is the upper part of the foramen where the neurovascular bundle is there, and the needle placement over here can lead to the dye spread into the facet joint. If there is a herniation over here, your needle is here, then it can go intra-discal as well. So this is a level below I did over here. So now you can see. So again, this is a filling defect. So this is the filling defect that I was talking about. So dye spread going from here and coming down from the traversing nerve root here, but it is not going into the scarred tissue. Now again, if you see here, so this is again intra-articular the facet joint spread over here. Now what I did again, I advanced my needle a little bit more, and now you can see the dye spread going retrograde into the anterior epidural space along this L5 nerve root. Okay, so this is the dye spread that you can see over here. Now, so this is again, I was doing it L2-3. Now you see a nice foraminal spread. Okay. So now this is the problem which I was talking about, that if you do in a static fluoroscopy, this is going to be the issue. That you will feel that wow, you did such a wonderful job. No, but when you do in a live fluoroscopy, then you will appreciate that this is going intravascular as well. Now this is a DSA, you can appreciate. So in a digital subtraction angiography, so this is the dorsal root ganglion. See how beautifully you can see a DRG. So this is a very nice dye spread along the DRG, which is very much desirable because all the pathology is at the level of the DRG. But if you can appreciate, so this is going a twig into the vessel as well. So to conclude, the interventional procedures, whether for diagnosis or therapy, should be performed only by physicians who have the extensive training required to evaluate such patients, interpret imaging studies in real time, perform the procedure in a safe manner, and analyze in real time the radiographic information obtained during the procedure. So thank you very much, everyone, for the patient hearing. Now, I'll be happy to answer any questions.
Thank you, Dr. Pravesh Kanthed, sir, for such an outstanding and insightful session. You beautifully covered the technical aspect of transforaminal and caudal neuroplasties, appropriate patient selection, interpretation of contrast pattern. So, Now it's over to our moderator, Dr. Nana Murkane, sir, to take up the questions. Nana, sir, are you there?
Yes,
Yes.
I'm here. Thank you very much, Dr. Pravesh. It was a wonderful presentation, as always. And as Dr. Anshul said, you covered everything. Especially, you covered and shown the images of complications, basically, or different aspects. That is very important. That is not seen frequently or many times in presentations. So, thank you very much. Any questions from? There's no in chat. There is no questions as of now. I think. So we'll wait for
anyone they want to ask, they can unmute themselves and they can ask.
Or you can type in a chat box. I will pass it on to Dr. Pravesh.
Thank you, sir. Wonderful presentation. No questions are there.
Okay.
Either everyone understood everything or nothing.
Now, of course, they must have understood
The
everything.
only thing which I would like to tell all the fellows is, this transforaminal injection, the caudal injections, they are on bread and butter. 80% of your spine practice is actually only this. Okay. If you master this procedure, I will again say master, it is very easy to do this procedure. Anyone can do this procedure even after seeing it 2-3 times. You practice yourself, and in 5th, 6th patient, you will be able to do it wonderfully. But again, the most important thing is clinical examination. What level you want to do, what procedure you want to do, what procedure, most importantly, what you want to do. Like this, just not transfemoral, whether you want to do a facet, you want to do transfemoral, you want to do both, whatever. So that clinical judgment is the most important thing rather than just putting the needle in the foramen. So I've always said technique is a technician's job. Anyone can master the technique. You would have seen the assistants and all, they know everything, but what to do in which patient, they don't know that. Right? So that is more important to understand.
Exactly. So I think there are no questions. Some question is there. Which method to prefer, sir, in subpedicular or combines?
Okay. So
there is a SAM. I don't know.
Which method to prefer will depend on what you want to do. For example, if you want, if clinically you feel that it is a L5 pathology. Okay, so whenever you see a patient and do a clinical examination, always think in terms of which nerve radiculopathy is this. Don't think in terms of which level herniation is this. Okay, why? Because L5 nerve root can be affected in L4-5 pathology also. In L4-5 pathology, in L4-5 disc pathology, when L5 nerve root is affected, that means the traversing L5 nerve root is getting affected. The same L5 radiculopathy or L5 nerve root pain can also come from the L5-S1 disc herniations. In that case, it will be the exiting L5 nerve root which will be causing the problem. Okay, so it will depend which level pathology is there and what you want to address and which procedure you want to do. But if broadly speaking, Campbell's triangle approach is better than subpedicular approach anytime. Subpedicular approach should only be reserved in cases where there is only exiting nerve root pathology. So that simply means
one more.
suppose
One
at
more. Okay, fine. Continue.
So suppose if it is a L4 nerve root pathology, then you can do L4-5 level subpedicular approach, because in that case your dye will be going only along the L4 dorsal root ganglion.
And there are one more thing. There are certain situations where there are a lot of osteophytes in suppose the particular area. So you would like to go in a combined approach in that particular case, or there are sometimes very large SAPs, very wide SAPs, and the combined approach becomes difficult. That time you can think about, even if you want to do combines, you can think about doing a particular approach. So this also
Yes.
can be one of the considerations. Yeah.
Yes, very good. Very practical thing, because yes, we do see very broad SAPs, and however lateral you do, you might not be able to go more lateral into the foramen. One more thing, in such cases, you can enter in the Campbell's triangle through the endoscopic needle placement approach. So endoscopic needle placement we will discuss afterwards, because I think it is not part of this talk as of now. अंकल एक लेक्चर में हूँ, थोड़ी देर से बात करता हूँ. Yeah, so one more question was there. Suppose if there is a dye spread in anterior and posterior, would you inject? Cent percentile inject.
100%, you're right.
Yeah, because this is actually if inadvertently this happens, then it is a blessing in disguise, because in this case you will deposit the medication in both, which is actually very much desirable, because many of the times, in such patients you will have some ligamental phlegm hypertrophy as well. So so your medication will go there also. I have encountered few patients after caudal steroid with pain after 2-3 days of intervention for L4-5 alpha 7 radiculopathy, and we can't repeat the procedure. What could be the reason for the pain or the next step? So if I'm understanding correctly, Dr. Devendra is saying that he has done a caudal, patient had pain relief for 2 to 3 days, and then the pain again came back. So what could be the reason for the pains? So reason for the pain might be because you would have injected a larger volume, because in caudal you inject lot of volume. And the pain relief effect would have probably been only of the local anesthetic. Maybe your anti-inflammatory steroid did not reach the desired area. That is one. Second reason can be that everything was done nicely, but then probably it is not an inflammatory in nature pain, and hence with your procedure and anti-inflammatory thing, the patient did not get a longer duration relief, and had relief maybe say only for the duration of the local anesthesia. So that again means two things: either the pain generator what you thought was a pain generator is not the pain generator, or the patient's body is not responding to it, and then maybe you will have to think for an endoscopic surgery or something else.
Maybe diluted steroid must have been reached the nerve roots, a very small quantity due to caudal.
Yeah, because in caudal you use a larger volume. That's
Larger
why.
volume. Right.
And caudal should be reserved, according to me, only for L5S1 herniations or L4-5 herniations in cases of sacralization. So that means only for the last well-formed disc, caudal should be performed. If it is above that, better to go for a transforaminal, unless it is technically impossible to reach through a transforaminal route.
Right.
Sir, what to do if the drug goes intradiscal, like you explained in one of the slides?
Yeah, very good question. So now suppose I am doing a dye study, and there is an inadvertent intradiscal spread. So my protocol is, what I do is I load cefuroxime antibiotic in 10 cc. Then I take 100 milligrams, 1 cc of it, and then inject intradiscally uh, the antibiotic, and then I remove the needle and again do a dye study. And if I am into the foramen, I complete my procedure, and the remaining antibiotic I give IV to the patient, and for 3 days, just for my peace of mind, I give IV and oral antibiotic. That's it. That's why this procedure should be done in a very sterile manner, because you never know when you will encounter intradiscal spread, inadvertent intradiscal spread.
Okay, sir. Thank you.
This is
And
one more thing.
one more
This is a
thing, one more
common.
thing. You can in fact inject steroid also intradiscally, because if there is a tear or something, the dye from the disc will ultimately leak out from the disc and the tear and will come into the epidural space only. So again, it will depend from case to cases, but yes, you can very well inject intradiscal steroid also. Now, when I'm doing a discography, so what I do is with I I mix the my dye with antibiotic,
Okay, okay, sir.
because we use Omnipec 350, right? So I
Yes,
usually
sir.
take 3 cc Luerlock syringe. So usually I take 2 ml Omnipec and I dilute it with 1 ml saline anyways. And in cases of provocative discography, in place of saline, I just add 100 milligram of cefuroxime.
Okay, sir. Thank you.
Sir, I
Okay, this
also
is
asked one question for the young fellows regarding the warning signs of dye spread. So, can you give some warning signs that young interventionists should be careful about?
Warning signs means, Anshul, that you should not inject it.
Yes, sir.
So warning signs, the first thing is obviously a intravascular spread. And as I said, intravascular spread, you will 100% miss if you are doing in a static fluoroscopy. Okay.
Yes, sir.
The second is intraneuronal spread. Okay. But intraneuronal spread actually is very difficult to do. Why it is very difficult to do? Because the patient will have immense pain as soon as you start injecting if it is intraneuronal. So patient himself or herself will not allow you to do an intraneuronal injection. But when we are starting our career without much, somebody to guide, then yes, because I have done intraneuronal injections as well. I won't shy away from accepting that, but in the early part of my career, yes, they happened.
Sir,
And
sir, how we can differentiate about the very inflammatory disc when we inject in the very inflammatory area, like in acute disc region, then patient will always have a pain.
yes,
With and if there is tight stenosis, there is little bit of pressure also.
correct.
but that intraneural pain will be extremely very severe pain.
Yes, sir.
Even
Yeah, so
inflammatory.
Anshul is asking that only for the benefit of fellows. So
Yes, sir.
Anshul, if I'm understanding correctly, you want to ask how will you differentiate between an intraneural injection which is painful and a highly inflamed disc which is painful while injecting, right?
Yes, sir.
Okay, so intraneural, as Dr. Nana is saying, it will be excruciatingly painful, and then you will be able to analyze the dye spread.
Mm.
So, and again, there is a lot of tactile sensation feeling when you should have when you are injecting. You know,
But one more thing, intraneuronal pain, this is injection, it will be very, it won't be a free flow. The epidural injection will have a free flow of the spread will be easy. Uh, and intraneural, it will be good amount of resistance will be there when it is intraneural. So that also can be a good resistance with severe pain. I think we can, think about intraneural injection.
oh,
Yes.
but I agree with Anshul. What Anshul is actually asking is because practically, even in case of a tight stenosis, or suppose if there is a acute fragment, and the fragment is mechanically compressing the nerve along with inflammation. In those cases also there will be severe pain. So whenever there is there is a so now suppose there is a severe pain while injecting and you have ruled out a intraneuronal dye spread and you want to proceed with the injection of your medication, do it very slowly,
Exactly. Right.
because usually we push, because pushing is good also, because you are washing away the cytokines, and that is also one of the methods of giving the pain relief. So but there are certain cases, certain instances where you should inject it slowly, and this is one of them.
Yes, sir. Thank you,
Correct.
sir.
Very good question, Anshul.
Thank you.
So, apart from pain in intramural injections, can we expect any other complications if we
Yes,
inadvertently inject?
yes. So I have seen myoclonus, I have done that also. So once the procedure was done, patient was shifted and suddenly patient started having involuntary movements, because probably that was some was intraneural and all. And in 2007, uh, so So there was a fashion of injecting lot of things into the epidural space. So lot of things means we used to add
Ozone.
Tramadol, we used to add clonidine, like we used to do in anesthesia practice. The volume was also large, so we were also
Hydrochloric.
evolving that time. So these all things increased. So actually, see, if you increase the volume and all, na, if you increase the level of your procedures, like suppose you are doing procedure at L3 for L4 5 L5 S1, so all these things are going to increase your rate of complication rather than increasing your outcome.
Okay, sir.
So I
Yeah.
always say that do a targeted procedures and interventions. Don't do canopy procedures, umbrella procedures, that this also, this also, this also. Facet भी कर देंगे, SI joint भी कर दो, transfemoral भी कर दो, कहीं ना कहीं तो तीर लग ही जाएगा. No, that is not right. Improve yourself clinically first, and that's why you have now 1 year fellowships and all.
Okay.
Another complication can be bradycardia, vasovagal. So we should always have a
Yes.
to watch on those things.
Yes, intraneuronal will cause bradycardia, will cause vasovagal. The first sign of that is patient will start sweating. Patient बोलेगा जी घबरा रहा है और पसीना आ रहा है. This I have seen personally. The first sign, even before the monitor can catch, the patient will say this.
Okay, sir. Thank you.
Okay, one more question. Lumbarization of S1, clinically, how to detect the nerve root?
See, clinically, you just think about the L4, L5, S1. You know, these are the three most common radiculopathies you will encounter. Obviously, anterior thigh and shin will be L4, lateral thigh and lateral leg would be L5, posterior thigh, hams, calf, and lateral 3 digits will be S1. So forget about L5 lumbarization, sacralization. You first clinically determine what level radiculopathy, radicular pain or radiculopathy is there, and then do the procedure accordingly. Always remember, choose your level according to the last well-formed disc. Last well-formed disc can be L5S1 and it can be L4-5.
Right.
Whatever it is, as per the MRI, it doesn't matter. You do the procedure according to your nerve root affected.
Right. Okay, I think most of the questions are covered. Very nice presentation and good discussion. I think thank you very much, Dr. Pravesh. It is very informative. Okay, so thank you.
Okay,
Thank
sir.
you all the fellows. Thank
We
you,
can
Dr.
conclude.
Anshul. Thank you, Dr. Pravesh
Thank
again.
Thank
Thank
you.
you, sir.
So we close the meeting.
Thank you, Dr. Nana.
Thank you.
Thank you, Dr. Anshul. And
Thank you,
thanks.
sir. Thank you, sir.
Yeah, thank you all. Good night.
Good night. Good night.
Yes, good night.